Welcome to Cracking Cancer, where we tackle the tough questions about cancer with real patients and world experts. Our mission is to empower the cancer community through education, bring transparency to the oncology system, and drive funding for critical cancer research. Whether you're facing a diagnosis, supporting a loved one, or simply here to learn, we're here to bring clarity, hope, and action to the fight against cancer. Hi, everyone. Welcome to Cracking Cancer. I am your host, Dr. Kyle Concannon. I'm a physician scientist at the University of Colorado, and I am now here joined with Sara Sandoval and Whitney Lewis. Maybe you can both take a second to introduce yourselves to our listeners. Sara, we'll start with you.
Hi, Kyle. Yeah, my name is Sara Sandoval. I am 36 years old, and I am currently a stage 4 triple positive metastatic breast cancer patient, living my life in Chicago.
All right. Thanks for joining us. And Whitney, a little bit about yourself.
Yeah. So I got my doctorate of pharmacy, and then I did 2 years of postgraduate residency. So I've got my board certification in oncology, and I worked with thoracic and head and neck cancer patients at a large academic medical center for 10 years as a clinical pharmacist there, seeing patients, helping counsel them. So I have a lot of experience with these drugs.
Yeah, you certainly do. And today's topic is we're going to be talking about one of the medicines that's commonly used in breast cancer. It's used in other cancers too. These are the taxane chemotherapies. They might be heard of as paclitaxel, docetaxel, Taxol. We have some other names. We'll go more into that. But many people are on these chemotherapies. Sara, you received them. Whitney, you did tons of counseling for patients who were on these chemotherapies. And we wanted to provide some information for the community because so many people are on these that a lot of people don't really know what to expect with them. So I think it's nice to have a baseline understanding if these may be in your future at some point, or you have one of the cancers that frequently gets these, that have some foundational understanding before you walk into the office as to what might be in your future and what to expect. So, with that in mind, Sara, I'd love to start with you. You were initially proposed a regimen, a chemotherapy regimen, when you were diagnosed that had these taxanes in them. And I'm curious, was there any particular sentiment about what taxane chemotherapies are when you were first offered a regimen?
So absolutely. My oncology team certainly went into what they were. Did I know what they were? Not necessarily. When you're first diagnosed with cancer and specifically metastatic cancer, you get the whole alphabet really thrown at you. It really kind of feels like you're in a fishbowl almost, and or I don't know if you guys remember like the Charlie Brown teacher, that adult voice that they had where it's like
Womp
womp womp
womp.
womp womp. Yeah. You hear people talking to you, but you don't really know what they're telling you, I would say. And that's kind of where I was at. And so what was extremely helpful for me, and what I highly encourage anyone who may be going through this whole process, is to sit down and have a conversation with your onco pharmacist, like Whitney. Um, I had the opportunity to sit there as long as I wanted. They answered all of my questions. They answered all of my husband's questions. We were able to talk through all of those possible side effects, why they're giving me these medications. We talked through the big one, specifically with nausea, and if I may need extra medication, which if they do offer that, I would highly suggest it. I take something called chlorperazine. I'm not sure if I'm saying that correctly or not, but
Nailed it.
that's how I say it. Which was Yeah, which was a lifesaver for me, right? So, they when you're going through these treatments, they give you a nausea pill first, but then they give you a little bit extra whenever you're at home and when you may need it, which is great. So when you're dealing with any type of cancer, like I said, the unknown is the scariest part. So having those conversations with your medical team, and specifically maybe the pharmacist, um, is really helpful when you're not knowing what your treatments are, and you don't know what your treatments are when you start. So what's gonna what's gonna really help you is to have those conversations with your care team, which is so key.
Thanks, Sara. So, Whitney, as a pharmacist, you had a lot of experience working with taxanes. What are taxane chemotherapies from your perspective?
So they're an interesting class of compound. So these are actually derived from trees. I was kind of digging into the history of taxanes to kind of try to understand, like, how did they get developed? Like, did Billy eat a lot of tree bark and then die the next day? Like, how did the early humans realize, like, that there's something medicinal or an effect in this? And I wasn't able to find how they discovered that, but apparently they've known about the kind of poisonous aspects of this type of tree since even like Julius Caesar's time. It's like the earliest recorded like casualty of somebody that like drank too much yew juice and died. They said even like the Vikings used to like maybe dip their arrows in like some of the sap from the tree. So just like very interesting that like humans have known for centuries that there's something in these plants. And then they started developing them in like the 60s, 70s, and I think got FDA approved in the mid 90s for breast cancer. So we've been using them for decades. And the way that they work, paclitaxel and docetaxel work very similarly, as you might guess. They're kind of cousins. They're both derived from this family of tree. Um, and when we think about like a cell, I think a lot of people have the tendency to picture like a water droplet and it's like real gooey and can move around really easily. But there's actually like this little tiny skeleton inside the cell. And when the cell goes to start dividing itself into two, that little skeleton needs to like be able to get longer and shorter like pretty rapidly to kind of accommodate the changing shape of the cell. And both of these drugs bind to that skeleton and kind of lock it into formation. They lock it into different formations depending on the drug. But them being set in space like that and unable to divide any further causes that cell to die. So, unfortunately, just like most other chemotherapies, these aren't smart enough to really know, like, ooh, that's a cancer cell. Like, I want in there. Let me ignore, this other totally normal, healthy cell. It kind of hits your more rapidly dividing cells. But for a lot of those cells, they are cancer cells. So that's kind of how they work is they kind of just stop the cell from being able to divide.
So, Whitney, why are taxanes used so commonly in cancer treatment?
I think because they do work in a very cell cycle specific way. But they're also again like they're not specific. So they do sort of hit those rapidly dividing cells, which really lends itself to like the rational combination with other chemotherapy agents. So these are drugs that can be used on their own. They're also very amenable to being combined with other chemotherapies, for example, like the platinums that we've talked about before, because you're kind of hitting the cell from like multiple angles. And from a side effect point of view, which I'm sure we'll talk about later, it's again very amenable to being combined with other therapies. And we know that there's a lot of activity with these drugs across a wide array of solid tumors.
Yeah, that makes sense. So, it sounds like since the taxanes work by stabilizing that skeleton, the cytoskeleton that cells have, that they don't really have that ability to divide comfortably and turn from one cell to two cells because they're kind of frozen. And since that phenomena is unique across all cancers, that it's used for a lot of different cancers. Does that
Exactly.
sound right? And for someone who is newly diagnosed with cancer and they don't yet know what stage they are, but they're trying to get a grasp of therapies that might be in their future, are taxanes used exclusively in certain stages, or might people get them either in the curative or extensive stage, depending on their cancer type?
I think that's a really good question. Because these drugs have such good activity, they're really considered a backbone for a lot of different solid tumors. And that can include neoadjuvant therapy or induction therapy to try to maybe shrink a tumor down before it's hit with surgery or radiation to try to cure it. It's also sometimes used after those like surgery or radiation to kind of clean up anything that might be left over in an adjuvant setting. Or sometimes in a setting where the real goal is just to keep patients feeling as well as they can for as long as possible in more of a palliative setting, then they're definitely widely used there as well.
Okay. So really broad applicability with the taxanes, multiple different cancers, multiple different contexts. So a lot of people could probably expect to see this in their clinical course at some point. Is that fair to say?
Yeah, I think it's one of the most commonly used types of cancer treatments for sure.
Okay. And we've been using the term taxane because that is the class of drug. So there's a bunch of different types of taxanes, and they're structurally pretty similar, or they work, fairly similar, pretty much the same mechanism, but there are multiple different types. Wendy, could you go into the different types of taxanes and the major differences between them?
So there's 2 to 3 that we would say are, like, the most commonly used. There are other taxanes, for example, cabazitaxel is really only used in prostate cancer, so a little bit less applicability there, but to your point, works the same way. The 2 major taxanes are paclitaxel and docetaxel. And paclitaxel has 2 different formulations. There's kind of a traditional formulation, and then there's another formulation that is, um, it's bound with, these proteins, called albumin, these little nanoparticles that help, keep the drug, like, soluble, so it kind of instead of being like a little powder, it truly dissolves into this liquid. When that formulation is infused, it's a theoretically a little bit better able to target, the tumor. We know that cancer cells may utilize more of this albumin, so it may get to the cancer cells a little bit more, efficiently. But traditional paclitaxel, anything that goes into your vein goes anywhere in the body. So that's kind of the other formulation of paclitaxel. And then docetaxel again, those are kind of the main three that I would say we use. In terms of differences, all of these drugs are very difficult to get into solution. So they are formulated with other things that help them dissolve, basically. And a lot of times people will have reactions to either of those products that are used to help these drugs dissolve. Um, they kind of have very similar side effects because they work very similarly, but there are some differences. I would say, like more broadly, paclitaxel is perhaps a little bit less harsh on the body's nervous system. So paclitaxel may have more um, neuropathy that's associated with that or numbness and tingling compared to docetaxel, which is a little bit more harsh on our body's bone marrow.
So when we're talking about the different taxanes, there is, on one hand, you're looking at what tumor type are you treating, and different tumors will be treated with different types of these taxanes. One might get docetaxel, one might get paclitaxel or nab-paclitaxel. Um, and some of that's just based on the studies that used it, but there's also side effect differences that might influence someone to use one versus another. Does that sound right?
Yeah, that's absolutely right. So if somebody's having an issue with their body's immune system, then you might want to switch from one taxane to the other. If someone's having more neuropathy, I'm much more likely to suggest, like, hey, they're having neuropathy. Let's hop over to docetaxel. Maybe we need to adjust the dose a little bit because it is a little bit more harsh on the body's bone marrow. So there's going to be these trade-offs. But they do again, both of these drugs cause both of these side effects. They're just a little bit different, and how intense they can be between the drugs.
Sure. Along the topic of trade-offs with the taxanes, sometimes we have different dosing regimens or dosing schedules. I know in breast cancer, you can do weekly dosing or every 3-week dosing, and that's just one example of many examples where you can alter the dosing schedule. If you're doing a dose that's more spread out, a lot of times we'll have to give more of the drug. And Whitney, can you speak a little bit to the balance and trade-offs between more frequent dosing at lower doses or more spaced out dosing at higher doses?
Yeah, so kind of similar to when we're thinking about switching between the drugs for different side effects, we can also think about switching between different dosing schemas. So you can get paclitaxel weekly, which is often done, for example, in breast cancer. Um, when we think about side effects for paclitaxel, it's not that it never happens if you give it weekly, always happens if you give it every 3 weeks, but it is a little bit more nuanced. So, things like the neuropathy or that numbness or tingling sensation, like if you've ever fallen asleep and woken up and, your hand's numb because it's in a weird position under your pillow, then it kinda gets that tingling sensation and that, sometimes like a little bit burning or just the numbness in general. That's more common with weekly exposure. Changes to our nails are also a little bit more common with weekly exposure. But when we switch over to every 3 weeks, then we start to see more changes in our body's immune system. So it affects our bone marrow a lot more at this higher dose. Patients may have more hypersensitivity issues because they're getting exposed to more of that diluent that helps keep it in solution. Nausea and vomiting for these drugs by themselves is actually pretty uncommon. When they're used in combination, then we start to see a lot more nausea. But even still, it is more nauseating to have a higher dose than a lower dose with paclitaxel. And then weirdly, some things kind of like muscle or joint aches, it doesn't really matter what the dose is. And that's pretty similar, I would say, for docetaxel, which can also be given weekly or every 3 weeks. We get a little bit more tearing of the eyes with weekly docetaxel. You also can get a little bit more fatigue with weekly docetaxel, and that may just be a symptom of having to come in every week and get treatment and have your schedule a little bit more interrupted. And then again, like the bone marrow, and then hair loss sometimes a little bit more frequent with the every 3 weeks. But so yeah, it just kind of depends on the drug and the schedule a little bit, but there are some differences. And if you're getting one versus the other, it's probably because they're trying to do a delicate balancing act of keeping everything just as effective, but try to customize it for what symptoms you specifically are experiencing.
And for the person who's hearing this and worried about one particular dosing regimen's side effects, once you start a schedule, let's say you start every week, can you switch at any point if you need to?
I wouldn't see why you couldn't. There may be, for example, in breast cancer, there was a great study many years ago that looked at weekly paclitaxel, weekly docetaxel, and then also the every 3 week versions of that and looked at patient outcomes. Um, so I think in the absence of some sort of data that's very compelling to say, like, no, we know absolutely this is the best regimen for you. And again, a lot of times these drugs may be being used in a palliative setting to help make patients feel better, in which case we're a lot more flexible with all of that to try to make it fit into your schedule. But I think that's always a shared decision that we would want to make with the patient.
Yeah, that's a sentiment I've gotten from patients in the past is people are worried that once they start a treatment course, that they're shackled to it. That we're doing this, these are the side effects. And I want it to be clear that if you start pretty much any treatment by and large, and the side effects are not manageable, the care team is going to help navigate those side effects, change the dosing regimen, give different supplemental medications that might help it be more tolerated. So the idea that you're starting with something that may cause fear appropriately, because there are side effects to a lot of the therapies we give, including the taxanes, I think it's really reasonable to have that fear. But know that frequently there's always a kind of an off switch. You can always change course as you're going through if things aren't tolerated. The care team is not interested in making you more sick from the therapy than you were before. So if that's a concern of yours, it's shared by your care team. Everyone wants you to feel better, truly. And when you're hearing about the side effects of the taxanes, keep in mind that there's flexibility with how these are administered. There's options of different types of taxanes. There are different dosing regimens. And a lot of that is at the disposal of the care team to help you feel better. So don't be too nervous when you're going into one of these regimens and you're seeing them hang the chemo. Uh, there's always room for optimization. And around that sentiment, Sara, you were originally treated with a regimen that contained taxanes. Did the care team give you any rationale for why they chose that particular regimen? Or was it more, this is standard of care, it's what we recommend?
Yeah, absolutely. So for me specifically, we already knew that I had to do chemotherapy off the bat, just from the scan results and everything that we had to do. So the main thing that we wanted to go in with is get the full body scan to see what of the medication we needed to be prescribed to me. So thankfully I didn't have it in my bones, so they ended up removing one of the medications that they originally said that they were going to give me. And my metastasis had went to my liver. So we initially thought we were going to go in with, excuse me, sorry, I forgot what it was. Is it THCP or what? I don't know
It
what
could
Yeah,
be
the
so that would be
THP.
THCP, right? So that's
Okay.
Taxol or trastuzumab, Herceptin.
Okay, yeah.
Uh,
Yeah. So I was THCP and now I'm THP is what I did. So I'm sorry about that. I totally lost my train of thought on, on that.
A genuine side effect of the therapy.
Yes, a genuine side effect of the
Mhm.
therapy. But so we went in with the THP because it was not in my bones. It wasn't invasive in my bones. The thing that we talked about specifically with mine is, since I am triple positive, the therapy that I received, my team told me that they knew kind of exactly where it was targeted and how to react to the cancer inside my body, which is, when you're dealing with stage 4 cancer, that's something that you certainly want to hear. And so to your point, Kyle, it can be scary. You're sitting in a room and you're having all these people come in, telling you what you're about to do, how you're about to do it. The nurses are in hazmat suits, basically. They're masking up to give you the chemo. So you're thinking, oh my goodness, this is terrifying. This is scary. This is going into my veins and this is going into my body. Why are they suited up like this? But on the other side, as soon as I started my chemotherapy, almost automatically, I felt better. I
Hmm.
must have been so sick that I didn't even know I was that sick, to be honest with you, because before I was diagnosed, I lived my life like a normal person. I didn't know I was sick. This is very new to me. I was diagnosed with de novo, which just means you are initially diagnosed at stage 4 breast cancer. And so I must have been that sick that I didn't know that I needed this type of medication and this type of procedure. I had weird feeling in my armpits. I was nauseous all the time. I was getting hot sweats all the time. And as soon as I started my chemotherapy, it was like a switch turned on and I actually felt better. And my oncology team tell me like I'm almost like an anomaly. Like most people don't have that reaction, but be thankful that you do have that reaction, because it is possible. Like, I live my life every single day now, and I did 6 to 8, rounds of that chemotherapy. I was doing so well that we were able to push through the 8 rounds of the Taxanes, which was great. And yeah, I mean, I walked every single day. I did not have any appetite loss. I continued to push through and eat whenever I needed to eat. Yes, you do have the side effects of, okay, I am really tired, but that also could be from the steroids as well. But I pushed through it. I got off of the couch and I wanted to continue to live my life. And actually, the chemotherapy allowed me to do that. It allowed me to feel like myself again, which might not be the side effect you were looking for, but it's how I experienced it, which is great.
Yeah, and your regimen, the THP, the T stands for the taxane, and the other things are antibodies. They're antibodies that go and bind to the tumor. So the taxane was the only chemo you got in that regimen. And there are side effects to the taxanes, like we mentioned, but you were mentioning that almost immediately you were feeling better. And that's something we actually hear a lot with chemotherapy. And it surprises people, particularly when people who have a large burden of cancer. because that causes systemic effects, that causes symptoms throughout the body. You were feeling nauseous, you were feeling night sweats. So those kinds of things, the chemotherapy will stop the cancer from growing, which is causing those metabolic effects. And frequently people have the reaction you had. I'm curious, when you were getting your infusion of the THP, the taxane, Herceptin, Perjeta, how long did it take you to feel better?
So I would say it almost instantly, like I said, a week or so. I also had a little bit of weirdness going on at the time as I was getting married whenever they were administering my first injection. So I kind of was thrown into the mix of everything. I had to start chemotherapy. I had to do my wedding. So um that might have taken some of the initial impact off of it. So I was just kind of thrown into everything.
A
But
little distracted?
a little distracted to say the
Yeah.
least, but I would say that again, I want to say within a week or so, that's whenever I really started feeling the uptick of I'm actually feeling really good. I'm doing everything that they're telling me to do. I'm eating the way they told me to eat. I'm taking my prescriptions the way I need to take my prescriptions. I have the nausea medicine there in case I need it. I did do my regime every 3 weeks. So I wasn't a weekly patient. I did do it every 3 weeks for me specifically. Um, I did start noticing some of the side effects in terms of maybe hair loss about 4 weeks from my initial infusion. And ironically, I mean, my hair started falling out right before my wedding on my rehearsal dinner. So I had to deal with that, but that is life. You know, there's things like wigs and whatnot that you come prepared because you know this is a side effect. So you always have to be prepared in life. And that actually, I was prepared for that. So that's not that big of a deal. But I would say really it started with kind of losing my hair about 4 weeks into the infusions. It started drastically coming out at that 4.5 week or so where I had to shave my head. And then it kind of progressively happened after that. So your hair, yeah, the head on your hair is the first to go. That's what I noticed. And then you start to lose things like your eyebrows and your eyelashes, and you don't even think about that when you're going through this process, but you do, and that's okay if you do. There's things like I have on right now with my eyebrows, and my eyelashes are steadily growing back, but those came at a later date. The initial one that you first see is certainly the head on your hair go, and that's a lot of time people have the hardest with it because it's attached to you. Your hair is attached to you.
Yeah.
It makes you who you are. But it gets better. It gets better. I am now about 6 months or so off of my treatment, and you can see it's definitely it's definitely down and gelled, but my hair is significantly growing back in all ways. My hair, my eyelashes, and my eyebrows. So it gets better.
Yeah, I would never guess that you have any cosmetic on your eyebrows right now. Um, that did not trigger for me, so it looks very natural to me.
Thank you.
Um, and Whitney, can you speak a little bit to that specific side effect, the hair loss, variability between taxanes in general? Does everyone who's on a taxane get full hair loss? Things like that.
I think those are good questions. I would say, regardless of the regimen or drug that you're on, it's more likely than not that you'll have at least some hair loss. I think definitely with the every 3-week doses, we see a lot more of that. I have had patients in lung cancer, for example, you might get like 12 or like 6 weekly doses during radiation. So those kind of like 6 to 7 lower doses, a lot of times people don't really lose very much hair. Um, so there are some exceptions, but in general, I think even those patients, they may have a little bit of thinning. And I think I always try to prepare people like just, if you don't, that's amazing, but like let's kind of process the fact that that may happen, but it's not permanent hair loss for the vast majority of patients. It's very rare to have permanent hair loss from the taxanes, but it is often hair all over the body. So you don't have to shave your legs, but then you also have weird things like I've had patients complain about like their nose running. And it's because you lose your nose hair. And it's just things that you don't think about there being hair until it's not there. And then, Sarah, I'd love to hear your experience as your hair is growing back. Is it the same like color and texture? A lot of times, I would have patients come and be like, "It's curly now. It was never curly before." Or it's repigmented, which is great. So I think everybody's journey is a little bit different, but for the majority of patients, I would say be prepared at least to lose a little bit. Yeah.
Yeah, Whitney, to your point, I think it's so important to go in with that mindset because, for reference, I had very long, thick hair. And whenever, like I said, that becomes your identity, that's who you are. I've had it for years like that. When you start losing it, it can be kind of hard. So, um, some of the recommendations that they gave me is like whenever you do start to see that hair loss come, maybe cut it up to your shoulders, maybe get a little bob so it eases into it and you're not losing your hair as drastically as what I did, unfortunately. And I would highly recommend anybody that's going through this to really consider just getting a shortcut when that time comes. To your point, too, you do start to notice a variety of weird things happening to your body. Specifically, since I didn't have eyelashes, I would get eye infections all of the
Mm.
time and like styes and things like that. And you just don't plan for that because you've never really had to do that because you've always had eyelashes that kind of help, filter out those things that may be getting into your eyes and whatnot. And so, um, as my hair is continuing to grow back, I am noticing some changes, and I am really much looking forward to those chemo curls. And it is very curly. So as you can see, it is matted down. But if this was not matted down, it would be out to here and curly. And it's actually it's beautiful. It's really beautiful. It's thick and. I was told that same thing. Like you can either get really, really thick, curly, chemo hair, or it might be even if you had curly hair before, you might get the straight and narrow type of hair growing back because it's completely new hair growth that comes after the treatment. And so that is what I'm excited for personally is to see the curls on my head because I did have thick hair like I mentioned, but I never had curls and it's nice. I like to see it come through.
I've had that with one of my patients when I was in residency. Now I treat lung cancer predominantly, and we don't get the same degree of hair loss usually. It's not to the same degree that breast cancer gets, at least not with the same frequency, those regimens. And one of my patients said her hair came back super curly. And she's like, I always wanted curly hair. I would have paid so much money to have this chemotherapy back, 20 years ago. And it's like, yeah, you never think about, like, as a provider, you never think to mention that as a pro. But I think people really do. People are, you've got to take your wins where you get them.
Yeah.
And sometimes the hair changes people really do like.
Yeah. One thing I will say, just as a patient from this patient standpoint, is like, don't be afraid to have a little fun with it too. Like, there's new styles you can try when you're going through the hair loss too. One of the things that I enjoyed doing is going with my friends and even my husband and going to some of these wig shops and getting a hairstyle that I may have never tried before. And so it's really fun as a patient if you have to go through something as extreme as what we're going through you can live a little bit vicariously through that and you can be somebody different and you can try new things that you haven't been able to try before because you are so attached to your hair. And so I think that's one of the positive things that I ended up doing is just kind of making lemonade out of the lemons that were given to me and trying new things and going out there and putting myself out there with things like wigs and when I wanted to feel like myself. And as we speak, I have a wig right here that's on my table that I frequently wear. It's real hair and it looks like me. So sometimes you want to look like yourself. Sometimes I want to look like this. This is a lot more manageable. You can get up and go with this. But other times you just want to be you and that's okay too.
Could you speak to the process of going out, getting a wig, finding where to get them? How does that work?
Yeah, absolutely. So I live in Chicago, as I stated before. So there's a ton of wig shops that you can go to, which is fabulous. But I ironically was going to get my eyebrows done for my wedding, and the woman that was giving me my treatment, she was like, hey, I don't know if you know this or not, because I was telling her what was going on and everything. Because you just when you have cancer, you just for me, it's easier for me to just talk about it because people can see what's going on, and you're like, oh, okay, I don't know how to address that. So sometimes I just talk about it. Anyways, she told me there's a Sam's Beauty that's about 15 minutes away from where my neighborhood is.
Hmm.
And the glory of that is they have so many discounted wigs that you can choose from. You go in there and it is this huge warehouse of statuesque heads with hair on them. And I mean, it's massive. And you get to go in there and you can try them on. You can try on as many as you want. Um, since this was a discounted place, they have real human hair, which if you are in the process of looking for a wig, you definitely want to do something like that because you're able to curl it, you're able to wash it.
Hmm.
You're able to try on a variety of things, whether that's lace fronts, whether that's glue or no glue wigs. Highly recommend the no glue wigs. They have these really cool bands that wrap around your head that essentially are like baseball caps. That's what it feels like. But they stay to your head and they make it more secure. And they also still have the lace front on it. So it looks more real. You can blend it in with makeup or whatever it is that you may use to kind of stick it onto your head as well. And so it truly looks like me. Whenever I go out, if I haven't seen friends in a really long time, they're like, how did your hair grow back that fast? I'm like, it's not, it's a wig. Also, the glory of having a wig too, especially in the summer months, I'll go out and I'll look like myself. And this just happened the other day. I went to a concert on Wednesday. I wore my wig. It was a great time, had a blast, took all the photos, took all the videos of me looking like me. As soon as that concert was ended, that wig came off. I needed it. It was so hot. You forget how hot your head is with hair on. So it was great to just take that off and be free. And you're just like instantly cooled off. You're like, man, I didn't realize that I do like short hair. And that's also something that you might come to terms with is like, hey, this is a new identity. I'm a new me. Do whatever works best for you. You can be yourself, you can look and feel like your old self, whatever works best for you. And so that is kind of where I'm staying at is like I like to be myself, but this isn't as bad either. So
No, it's great to hear that perspective. So many people are worried about the hair loss because, like you mentioned, it's an identity defining feature. Like, same with, people who have to have mastectomies or, when you're changing a fundamental part of your body that people can notice, that's really vulnerable. So it's so nice to hear. Here are some of the ways that you can roll with the punches and even use this as an opportunity. Maybe you wouldn't have wanted the opportunity, but it's here and here's how you make the best of it. uh
yeah.
what was the name of the place that you shopped at for the wigs?
Sam's Beauty. I'm not sure if that is a nationwide chain or not, but they have several here in Chicagoland area,
Hmm.
and um, you can go to some of these boutique wig shops, and that's perfectly fine to do that. But sometimes these wigs can be thousands and thousands of dollars.
Hmm.
It's not in a budget for most, and so you can go into a place like Sam's Beauty, and you can get a really nice, real human hair wig for about 175 to $200. And so that still may be a splurge for some, but if that makes you feel like yourself and feel like you, I would highly recommend it because I mean it is life changing for someone and just wanting to be you when everything was stripped from you is so important. So if that $175 or $200 makes you feel like that, do it.
Yeah, that's great advice. And something that I've heard from patients seen is people have a perception when they're on some of these therapies that all their hair will fall out. But I think, Whitney, you mentioned many patients have varying degrees of hair thinning. So the hair can not all fall out, but a lot of people will shave their head because it doesn't look normal when a majority of the hair has fallen out. So I think even if all your hair doesn't fall out, the opportunity to go and look at some of these things and even like ahead of time, start having fun with it probably early, preempt yourself, get used to the idea. Um, I think that would be a good way to cope ahead of time with whatever degree of hair loss occurs. Along those lines, there are a lot of therapies that we offer in cancer around taxanes, one of which is the cold cap and things that can help prevent hair loss. Whitney, I'll start with you. Do you know of any strong data that supports that these things work?
There are a couple of trials. I want to say they were in breast cancer patients, because women generally care a little bit more about the hair. Um, and that's a population that's mostly women. So I think with the cold caps, they do help based on, like, what I remember about these trials, but it's not like you get to keep every strand of hair. Um, if they work, they're still, like, you should expect to lose about 30 to 50% of the hair. So I think, for some people, that might be absolutely worth it, and for others, they're kinda like, "Well, if I'm gonna lose maybe half my hair anyway. Like, I don't wanna sit for hours with, like, the cold cap." I think that can also be uncomfortable for some patients. It can be very expensive. It's not always covered by insurance. Um, and they're still being studied. There is, like, a theoretical risk, that because we're restricting blood flow to the head, that if your cancer were to ever come back, you could have, cancer, like, in the skin of the scalp. Or does it change the frequency with which you might have cancer that comes back in the brain, for example, just because there may be less blood flow there? So all that's still ongoing, again, theoretical, but that would be like a potential consideration to discuss with your care team.
Sarah, did you use a cold cap?
Yeah, I can touch base on that. So, my treatment center definitely did not offer that. There are some treatments that do provide that as a service for their patients. To Whitney's point, it was very, very expensive. And so,
Hmm.
I've actually talked to a few of the patients in our hospital that are willingly doing it. They pay out of pocket and they have to um they have to haul all of this massive, it's almost like a really, really huge cooler with them everywhere that they go. It's more of a long process of actually putting it on their head, getting it ready, getting it prepped. And so for me, it wasn't worth it because I pretty much knew that I was going to lose my hair. And to Whitney's point, if I lose 50% of my hair, I mean, it wasn't worth it for me, to be honest with you, financially and or physically. For me, I was in and out of my treatment in 2 hours. If we were to do cold capping and everything else, that would add on to the process of an already very, very long day, that I didn't want to necessarily tack on to my time at the hospital. And so, again, it just wasn't worth it to me. It seemed like a very long commitment for maybe not the best results, in my opinion.
That's the sentiment I've heard from a lot of providers too, is a lot of providers will offer it. But I think in at least the circles that I've been around, there isn't a lot of belief that it's going to prevent the meaningful hair loss. It might prevent some hair loss, but it's not going to prevent all of it for most people. So I don't know if I think it's offered, but there's not a lot of belief that it prevents hair loss, full stop.
Yeah, and as a and from a patient standpoint, you're at the hospital, even though your treatment's 2 hours, give or take, you're at the hospital roughly from, like, 6 to 7 hours because you have to go in, you have to 1, you have to get there, 2, you have to do your blood work, 3, you have to go talk to the oncologist, then you have to go up to the treatment center and infusion site, and you have to then get prepped and all that stuff, and just adding on any additional time to a already hectic, tiring day um, might drain your energy that you may need, specifically when you're going through treatments like this.
Yeah, this is something that's come up frequently with different patients on the podcast is you really have to prioritize the things that you accept into your whole care plan. There's only so many things one can do in a day and so many things you can attach your emotional energy to. So yeah, it's important to be kind of selective about what those things are when they're not necessary. So, Whitney, we had mentioned that when people get taxanes, they're getting medicines with the taxanes to prevent some of the symptoms of the taxanes. Can you speak to what some of those medicines are?
Yeah, absolutely. So, I think, Sarah had already touched on this point before. We always want to make sure that we're giving nausea medications to patients. So, There will always be some nausea medication before the taxanes, whether they're given by themselves, even though they don't cause, for most patients, that much nausea, or in combination. And the most common one that we would give is a steroid. It's called dexamethasone. And that actually, for example, for docetaxel, serves multiple purposes. It helps with nausea. It helps prevent patients from having hypersensitivity or kind of an allergic type reaction to the drug. And that steroid also helps prevent a side effect that can start to happen after about 6 to 8 doses on average for patients, and that's some fluid retention in our legs or our lower extremities. That's called um, edema, and that can happen because the little blood vessels kind of get a little bit leaky, and taking a steroid can help prevent that. So sometimes patients will also take a steroid for a couple of days after they receive the chemotherapy, and that could be for nausea or for the same syndrome. Um, and then paclitaxel, it's formulated with something different than docetaxel, which patients are often a little bit more likely to have a reaction to. So we usually have a little bit more pre-medication. So in addition to the dexamethasone, there's often some IV famotidine or Pepsid, as well as some Benadryl to just really round out kind of trying to prevent those reactions to the drug.
Okay. Yeah, so that's clear to prevent nausea predominantly, some other reactions as well. And the taxanes come with other side effects that we don't necessarily have pre-meds for, but there are things we monitor for. Whitney, can you speak to some of the most common side effects of the taxanes?
Yeah, I think, things that I would always make sure to counsel a patient on. We've talked about hair loss. I think that's a really big one. Um, Patients' immune systems being down, so those white blood cells, which help you fight infections, platelets, your red blood cells as well, which, kind of prevent you from being anemic and give you a little bit more of that energy boost. We can sometimes see changes to the nails. They can become discolored. Sometimes they get like ridges or more brittle or very thin sometimes. Changes around the nail bed. It can become like red or inflamed. It seems like small potatoes, but if you're a patient that's getting really constipated, I think, that's always worth discussing as well, is like diarrhea. That neuropathy or that numbness and tingling sensation is also really big with the taxanes, and then fatigue. And then docetaxel can rarely cause some redness or tenderness on the palms of our hands or the soles of our feet. And these drugs are also a little bit more likely to cause some tender sores in the mouth. So those are kind of like the big things that I would want to touch on with patients. Nobody generally gets all of these side effects, but they're common enough that I think hearing about it and being prepared and forewarned can be really helpful for patients to feel more empowered to kind of manage some of those side effects if and when they come up.
Sarah, did any of the side effects that Whitney listed resonate with you?
So yes. So the steroid is definitely a game changer. So I just wanted to touch base on that just for maybe somebody that's going through it. So for me, I had to take the steroid 2 days before treatment and then a day after the treatment. So I took it for a total of 4 days, leading up to the infusion. And I can say that it is definitely a tremendous, life changer and how I felt. The big side effect that does come with that, or the downfall of it, is the steroids do keep you up. So even though you are going through your infusions, you may be a little bit tired. I always found that as soon as I came off of that steroid, I was actually able to sleep, because some nights I would be up till 3 a.m., 4 a.m., and have to go to the hospital by 7 a.m. And so that can be a little tiring. But to Whitney's point, actually, it does help tremendously with nausea. So, and I didn't have any swelling or things like that too during my entire treatment, which was greatly appreciated. The one thing that they did tell me specifically for the mouth sores too, and what I religiously did, is anytime that I ate anything, it didn't matter if I was eating a snack or if it was a meal, I brushed my teeth immediately afterwards to kind of help prevent some of those sores that may come along with the treatment. I didn't end up getting any of that. But also my team had told me that there are some other things that we could try, specifically with salt solution and water and hot water to kind of help ease some of that pain that comes with some of those mouth sores that patients do get. The one thing, and it's probably not a topic that most people do want to talk about, is you do get upset stomachs kind of religiously. At least I did going through the treatment. I would say that would be my biggest downfall that I did have is an upset stomach. And I just took Imodium with it, to be honest with you, and it helped almost right away. Um, funny backstory to that. My husband and I, we like to go on day trips when I was in treatment. You do have to watch your blood count naturally. So if you are low and you're white or you're red, you don't want to be traveling. But I did get the green light and the blessing from my oncology team. But one time we went and it was from Chicago to New York, and I had an upset stomach the entire time from on the plane, which was not a pleasant experience. But as soon as you pop that Imodium, I mean it does wonders for you too. But I would say those are the biggest side effects that I did have. Is just the tiredness, mainly from the steroid that you do have to take to prep for some of the other side effects that you may have, and then an upset stomach.
Did you vomit during your treatment course?
I did not. So I anytime that I did feel that nausea coming on, I just took the medicine that was prescribed to me, and it does almost kick in instantly for you. I think it's water based. That one of you may be able to correct me on that, but from what I remember, they tell me it was water based, and so it just helps a lot quicker than your over the counter type medications. But yeah, I took that and I really didn't have a problem. There was no vomiting for me. Um, I honestly, I walked 3 to 5 miles every single day that I was doing my treatment. I would say the biggest advice that my one of my chemo nurse gave me, and it was the first one that I had during my first infusion. She said, "Get up and don't let this beat you down. Whenever you feel tired, get up off the couch, just move. It doesn't matter if it's for 5 minutes, it doesn't matter if it's for an hour, get up and move. Whenever you sit on that couch and you just succumb to it, you're going to be more tired." And so that kind of stuck and resonated with me. And that's what I actively did. I got up and I moved. I have a walking pad that I have in my house that I would, if only I could do 5 minutes, I would do 5 minutes. If I could walk a mile, I would walk a mile. And she said the same thing with eating as well. So if I wasn't hungry, because a lot of the time people are very sick, they get nauseous, they don't want to eat because of the side effects of the medication. She said, eat a little bit. Doesn't matter if it's a bite, doesn't matter if it's a whole burger. Get something in your system. And I truly do think that's what saved me through my entire process is I didn't let the thoughts get to me. Two, I just listened to the advice that they gave me. I got up, moved my body, ate, rested. It's okay to not be on go mode all the time. And that was hard for me to learn. I'm a person that is very, very active. I have a full-time job. I have a contracting business. I go to the gym religiously. Have a very active social life. And so while that did have to take a back burner to some things, you may not be allowed to go out and see your friends in the normal setting that you usually do. You may not be able to go out and go to that restaurant unless you have a mask around your face and you're protecting yourself. The main priority should be you. And so some of that does change, and that's a little bit hectic, but it's worth it in the long run. And so that doesn't mean that you can't go out and have a social life. It just means that you kind of have to slow down, slow your pace, and just listen to your body and don't overdo it, because that is also going to be a game changer for you. To your point, you don't want to exhaust yourself. So it's okay to say no when needed.
Yeah, I think it's great to hear that despite having a lot of the symptoms that occur with these taxanes, you were still able to go live a normal life, albeit, with some compromises, with some reasonable compromises. And I think a lot of people, when they're diagnosed with a cancer and they're going through a chemotherapy course, they have these ideals as to what is the most healthy thing, so they try to optimize in a lot of ways because those are things that are within your control. But particularly when it comes to food, I love what you mentioned about eat what you can. And that's the similar advice that I give. It's like people, they try to cut out all sugar. They try to do all the, these cancer fad diets. And the reality is calories in are better than not calories in when
Hmm.
you're not feeling well. It's like if you want to have, half a pint of Ben and Jerry's ice cream and that's all you could tolerate, this native Vermonter is all for it. We need to get Ben& Jerry's as a sponsor, but I don't think that's going to happen.
Put
Um,
some protein powder in there. Absolutely.
Okay, yeah, pharmacist here is like, "Oh, well, we could probably make that healthy to some degree." No, yeah, and, you do wanna have your pure protein sources, but sometimes people don't tolerate much, and the
Yeah.
reality is what you can tolerate is better than not eating.
Yeah.
So I think it's nice to have the ideals and work toward those ideals, but, what you can do is good enough. It has to be good enough to get through.
Yeah, to that point too, you also are restricted in a lot of ways in the things that you can eat. And Winnie, maybe you can talk to a little bit more because you're probably way more knowledgeable than I am on it. But I was just kind of baffled of the things that you cannot eat. Like you can't eat raw vegetables, you can't eat raw fruit. You also can't take a lot of vitamins, which when you're going through cancer, you think, oh my God, I need to take all these vitamins to make me feel better or whatever. I personally, my team told me I could not take those, and so that was something that I used to take every single day pre-cancer to try to fight off sickness, and now they're telling me that I can't take it because of you don't wanna do more damage to what is already going on in your body, right? So, you're already getting a lot of heavy medicines that are impacting your body, and rightfully, they're fighting cancer for you, so you don't wanna throw in any other mix, and so I just had regularly talks with my team, my onco pharmacist. I would shoot them anything and everything that came to my mind in my mind chart. If, hey, can I eat this? Hey, can I take this? They would give me a simple yes or no answer, and based off of what they gave me, that's what we did. And so, um, yeah, I just was kind of baffled by some of that because to your point, you think you have to cut out all the sugars. You think you have to eat extremely healthy, which is that is important, and the protein is extremely important through all of it as well. But it's just kind of baffled me that you are not allowed to eat raw vegetables and raw fruits and things that you think would be a big impact for you.
Yeah, the do no harm is really important in this setting. So things that I'm more worried about infection risks than I am about the pure dietary optimization. You of course, and that's why we do things like Ensure, and like we do want people to do those things, but some people develop pretty aggressive food aversions and they can only tolerate certain things. And I don't want to discourage people to say, oh, that's unhealthy, don't eat it. It's like, no, like nutrients are healthy. You need food as medicine, as we term it. But along the lines of what you said as to what I'm hearing, interactions are concerning. Whitney, can you speak to some of the things that interact with taxanes that people will want to be cautious of or talk to their care team about?
Yeah, I think that drug interactions and things like supplements, vitamins, that comes up a lot with our patients. So I will just caveat that like 50% of known drugs get broken down in the liver through this family of enzymes. Um, and taxanes are also one of them. So there are a lot of drug interactions with the taxanes. That doesn't mean they're all necessarily going to be big no-nos, big clinical relevance, but there are some types of medications that we would say like, ooh, I would probably avoid that, because that does have an interaction, or at a minimum, at least please talk to your care team, even if it's just like an herbal supplement, or multivitamins over the counter. Even some of the medications that we give you for nausea can interact, right? But we know that, and that's kind of a something that we're already taking into the calculus when we make these prescriptions for you. So there's a lot of common drugs that can interact, and taxanes specifically because they get broken down in the liver through this enzyme system. They have a lot of drug interactions. So anything new, anything that you're taking, even if it's something that you don't like think of as like a drug or a medication, I think is just really important to tell the care team. And that doesn't mean you can't take it, but we do want to be aware of that. And then it may be that we need to make a little adjustment to something, one way or the other, to kind of help with that.
And Whitney, can you speak to like what happens if someone's taking something else that either increases or decreases the liver effectiveness? Like what are the risks of those interactions?
Yeah, that's a really important point, I think, as well. So, a lot of these drugs, when we prescribe you chemotherapy, I'm looking at all of the way your organs are functioning. I want to look at all of your labs to kind of see, like, where is Sarah at today? But I'm also looking at how tall is Sarah? How much does Sarah weigh today? Like how much space, are you kind of taking up? So I can kind of help understand what the right dose is going to be for you. It's very individualized for every patient. So there's sort of a window that we want it to fall within. So if we're taking a drug that prevents our body from breaking down the chemotherapy, more is not necessarily going to be better. It's not necessarily going to be more effective, but it definitely may have more side effects. And same thing if we're taking a medication that's like inadvertently, to you, breaking down the paclitaxel faster than we intend it to, and your body's clearing it faster. We also want to make sure that we're within that dosing window and we're giving you as much drug as we intend to, right? I think the last thing we want to do um, is take a medication that might make the chemotherapy and all of the side effects that you're enduring any less effective than we intended to.
Well, and speaking of side effects, one of the ones that we haven't touched on yet in detail is neuropathy. I know when people are on the taxanes, we worry about neuropathy because this is one of the symptoms that often gets better, but may not get all the way better. So we're really careful when we're looking at when we're evaluating patients while we're on these medicines to look at their neuropathy and make sure we're really careful about it. Sarah, can you speak to if you developed neuropathy on the taxanes?
So I think I'm a little bit odd where I kind of had neuropathy before I
Hmm.
already went with my procedure. But it didn't worsen, I would say. So there's things that whenever they were giving me the chemotherapy, we would put on mittens that had ice packs on them for both my hands and my feet. And they would just basically tell me, sit with it as long as you can. The more that you can sit with it, the better that it will kind of help with that neuropathy in the future. And so I today don't really have anything. It might occur every now and then where my hands do tingle. To Whitney, I think you pointed out earlier, it kind of feels like when your hands fall into sleep or you get tiny little pricks in your all maybe your surrounding hand area, either on the bottom of your feet or just in your hands in general. And sometimes you kind of have to wake them up. But outside of that, it's nothing that I really experience prolong. It might only last a minute or two, and you're like, oh wow, I have this going on in my hand. I just kind of make a little bit of movement for them, and I move forward with it. But yeah, I would say if they offer you the mittens, definitely take them up on it. You can wear socks with them and you can put things on your hands too to kind of help with the coldness of it. But for me, I would say that was a tremendous help in helping prevent it or prolong any other reoccurring neuropathy that I may have.
Whitney, could you speak to some of the symptoms of neuropathy? What do we mean when we say neuropathy, and what can we do to potentially treat those symptoms?
Yeah. So the way I try to describe it to patients and the way that I've had patients describe it, what it feels like to me, we kind of call it like a glove and stocking neuropathy. So kind of the areas if you had on a glove or socks, that's typically where we experience that neuropathy. It's not like, oh my gosh, my left thigh started tingling today. It usually starts in our fingertips and or in our toes. If you think about it, that's kind of where our ittiest bittiest blood vessels are. They're just more flat. They're more fragile. That's where all of our little nerves are. And so they're more vulnerable, and that's usually why they start there. It can feel like a numb sensation. It can feel like a pins and needles. I've had some patients say it feels more like a little bit more like electric than just the pins and needles. And typically starts in the tips. And if we keep giving you the same dose at the same frequency, generally speaking, it will start to creep up your fingertips, creep up your toes. Now, if your big toe goes numb for 30 seconds twice a week, I I don't personally get too excited about needing to make a change to your regimen. Um, but if it starts to happen more often than not, we don't want it to get to the point where you can't button a shirt or your feet can't feel where the floor is and it becomes more difficult for you to walk. And sometimes even after the last dose, it still gets worse for a few weeks before it kind of plateaus, I would say. And then kind of depending on how severe it gets, it can take a very long time to get back to normal or to what your new normal is. To Kyle's point, it may not ever get back to zero if that's what you experienced before. But we hope with time that those nerves do start to heal more. In terms of preventing, there is some data for the ice packs. Most of that's from like big, looking back at lots of little trials, trying to understand if we put all of these patients together in like one big trial or a meta-analysis, to have 1,000 patients instead of 100 trials with 10 patients. What's the real effect? And it seems like that there probably is some benefit to the ice packs. It's not something that I ever really encouraged patients to do. The evidence isn't that strong, and I have had some patients say it's really uncomfortable. But from a risk perspective, I don't see any issue with wanting to use the ice packs. And then from a of medication standpoint, things that we can try. I think like duloxetine or Cymbalta is its brand name has some data. It's a little bit less convincing in the patients that got taxanes, but I think is still worth a try given its side effect profile. For most patients, it's not tremendously high in cost. Or there's other drugs that we can try that we extrapolate from patients that get diabetes and have kind of a similar syndrome. So those are kind of the big things that we would try, and then just keeping an open dialogue with your care team. We want to understand, and at the end of the day, you're the boss. So if you say like, I'm having some neuropathy, but like I don't want to change my regimen, then I think that's a very different conversation than I'm having side effects and I need a change. Like it can't get any worse than this. I can't tolerate it.
Yeah. Oh, go ahead,
Kyle,
sir.
just on that note real quick too, is I can't express that more than what just Whitney just said. You have to advocate for yourself. You are the boss running the show right now. They help and they assist with you. Your whole entire medical team does, but you have to speak up and you have to let them know what's going on. And that's kind of what put my mind at ease when I'm going through all this, because they are telling you things that you can get neuropathy and it might not go away and X, Y, and Z. But you have to have that open communication with your team, because that's the one thing that put my mind at ease a little bit, is knowing that, okay, if I let them know that I am experiencing this neuropathy and it's pretty consistent, there are other drugs out there that may help redact what's happening in my body right now. And so that did put my mind at ease. But it can be scary at the same time to just communicate for yourself, but it has to be done. You have to fight for yourself because you're the one that's actually going through this.
Yeah, and you should have I would add to that you should have a really comfortable relationship with your care team, that they care about you and they want to work with you for your best goal, whatever that means for you. And I think specifically when it comes to neuropathy, because symptoms of neuropathy can be permanent. So we really are nervous about people when they're no longer able to button their shirt, when they're picking up mugs and it falls through their hands because they can't sense very well anymore, if it compromises your walking. Those kinds of things we really care about, because we can make changes that we don't think will have a dramatic change in tumor dynamics over time, but they might dramatically change your symptom profile. So it's not necessarily that the route you're on, the medicine you're on, is the best and only way to do it. It could be best practice right now, but subtle changes could be really helpful for your symptom profile and not really increase your risk all that much. So those things are really, really important to bring up, but it's always individualized, and you're the captain of your own ship. We're all here, we're the supporting team. Um, but neuropathy is definitely one of those ones to bring up. Nausea, fatigue, those things we want to help with, but they don't tend to be permanent. The neuropathy is one that's permanent. So if you have a threshold to bring things up, lower it a little bit for neuropathy. Uh, and I think now's a good time to wrap up. So maybe Sara and Whitney, starting with Sara, what's a piece of advice that you would give someone who's newly diagnosed with a cancer and has taxane chemotherapy in their future?
Yeah, have that open communication with your team. It does get better. They're there to help you, to your point, Kyle. And as soon as you cross that bridge, you ring that bell. It's night and day difference. I mean, you're a whole different person by the time from you do ring that bell to when you started. And so it is very scary. You're going through the whole process. You're seeing, as we talked about, people suit up and all of that. But by the second or third time that you're in there, you know your care team. They know how to talk to you. They know how to react to you. They know that you may have questions and you may not have questions. It gets easier. It 100% gets easier. Um, I would say the one thing, and Winnie, I think you touched base on this too a little bit too, is I am HER2 positive, so I do have to go in and I have to talk to my medical team every single time before I do get my infusions, and that also does put my mind at ease. Like, I can see what's progressing, what's stable, what's regressing. I know if something's a little bit off because I do have to go in and look at all of those results, probably the same results that Whitney looks at, to say, like, yes, she can move forward with treatment, or no, there's something maybe a little bit off. And so I have to go in and do have those conversations every single time that I do receive treatment. And so that also does put my mind at ease. And the biggest thing that I can say is it gets better. Hang in there. You may have some of these side effects, but ultimately you're taking this medication and you're taking this procedure to help fight what is in your body right now that is harming you. And so stick with it, stay strong. You will get through it.
Well put. Whitney, what piece of advice would you give to someone who's getting ready to prepare for Taxanes?
I mean, I think I would echo what Sarah said, try to have a really good, open relationship with your team. There are no stupid questions. And if you have it, I bet a dozen other patients have asked it over the years. And we would way rather you feel comfortable and reach out to us so we can kind of give you an answer that's a little bit more tailored to you specifically than what you may be able to find on the internet. So we want you to ask those questions. We want you to be involved in your own care, and kind of have that sense of power over what you are able to control in that way. Take it day by day, dose by dose. And if there's anything new or unusual going on, when we talk to our patients, I try to highlight what are very common side effects, and what are some more rare but more serious side effects. But there's still a chunk in there that's maybe more rare, but not necessarily serious, like go to the ER serious, because I just don't want to overwhelm you, and we don't have time to go through everything. And to Sarah's point too, at some point it's just like wah wah. No one wants to hear me talk that long. So if you're experiencing anything new or unusual, it could absolutely still be related to the chemotherapy. So reach out to the team and see if they've got any tips, tricks, recommendations. Like, is this related? Should I be concerned? We want to hear from you, and we want to help support you in any way that we can. And AI is getting pretty good, but we're not mind readers yet. So anything, that comes to mind, please reach out.
Kyle, one additional thing that I think it would be important for just anybody going through it too is just kind of really think about your mindset as well. Like, if you're thinking positive and you're going in and you're knowing that you are bettering your body and everything else, it does make a difference. For instance, one thing that I like to do too is I go to Northwestern, right? There's a huge medical center. It's a huge medical cancer center here in Chicago. And you see people day in and day out because you're there too doing the same treatment that they are. I like to bring sometimes, it's probably frowned upon, but like cookies or cupcakes or something along the lines of that, just to kind of help cheer people up in this center, because we're all going through it. You're there for a particular reason, and so is that person next to you. And so just giving a little bit of happiness to somebody that may be having a hard day, may have received good news. It's nice to see too. And so just kind of going in with a positive mindset and just realizing that you can make a difference to somebody's that's going through the same thing that you are too. It's beneficial for me. I think it does more for me than it does for that person, but it helps me get into that positive mindset. I bring them for the nurses. I bring them for my care team. I bring them for the patients. And just to see everybody's reaction does make that infusion that much more special, I guess you could say, or that much more manageable of just getting through it for the next hour or so. And so it's just a great thing to just really focus on, I guess you say. It takes your mind, it takes my mind specifically off of what I have to do. And I think positivity does make a night and day difference for some people.
Yeah, I completely agree. I think doing the small acts of kindness for other people probably benefits us more than it benefits them. Although it does benefit them, but I think it's a really it's a good act to make you feel better too, to start thinking, or to think about other people and act on that. And building on that a little bit, I would just say that what you're going through when you're on these types of chemotherapy is hard. What you're doing is hard, and it's okay to acknowledge that. It's okay to let yourself feel bad and acknowledge that that's okay. You are doing a hard thing, and you're allowed to not enjoy it. But the way, the only way out is through. And to what you're saying, Sarah, managing to have the most optimistic outlook and identifying ways to make the lemonade out of lemons is going to be what increases your happiness as you're going through it, because you don't have a lot of choice if you're going through this regimen, and that there's going to be some downsides. There's going to be some side effects. So doing good things for other people, and I think giving yourself a break when you're not feeling so great, that it's okay to not feel great. Like you can give yourself that. You can feel, you don't have to have that guilt. And you have a huge community of individuals who are on this too, who hopefully you can identify through community resources, patient advocacy groups, talk about it, and have some community over the shared suffering. And a lot of these people have really effectively used their suffering to better help others. And I think that's another way that people find meaning in suffering. So with that, I think it's probably a good place to stop. Thank you everyone for listening, and thank you, Sarah and Whitney, so much for joining today. I learned a lot from both of you, and hopefully those listening did too. Thank you for joining us on this episode of Cracking Cancer. If you found this helpful, please like, subscribe, leave us a review, and visit crackingcancer.org for more information. Every dollar we earn goes directly to furthering the podcast and supporting vital cancer research, because together we can crack cancer.